Good day. I am Dr.K Gireesh, physician, neurophysician and neurosurgeon. This is the RNA series number 75. RNA is nothing but the random questions in neurology and neurosurgery with answers by Dr. Gireesh. This is in fact to benefit the practitioners of neuroscience and the medical field for a lifelong learning and also for public awareness. In this series, I am addressing what are the features of empty sella syndrome, ESS. Empty sella syndrome is a condition in which the sella turcica, the bony cavity containing the pituitary gland, is partially or completely filled with cerebrospinal fluid, causing the pituitary gland to be compressed and flattened against the floor of the sella. Despite the term empty, the sella is not truly empty. It contains a compressed pituitary gland. There are two types: primary empty sella syndrome and secondary empty sella syndrome. Before that, now who coined the word empty sella? Now in 1941, Bush, in a series of autopsy studies, found that 5.6% had a defect in the diaphragma sella, and the arachnoid had herniated into the sella, enlarging it and displacing the pituitary gland inside the sella posteriorly and inferiorly. He coined the term empty sella for this anatomical finding. However, the term empty sella is in fact a misnomer, as the sella is not completely empty and the pituitary is always present both anatomically and functionally, although often it is displaced downwards and compressed by the CSF pressure. Birchland and Kaufman et al. In 1968 elucidated the condition further with anatomical and radiological studies, and in fact Kilpauk et al. 1974 called this as an intracellular arachnoidocele. And the types of defects in the diaphragma sella, based on a study of 788 sellae in patients without a history of pituitary disorders, they classified the diaphragma sella, the one which is covering over the sella, the diaphragma sella, into the following categories. There are three: type 1, 2 and 3. Type 1A, the diaphragma sella forms a complete seal. Type 1B, a slight tunnel-shaped depression is present in the intact diaphragma sella. Type 2A, there is an opening about 3 mm or smaller in the diaphragma sella, exists around the hypophyseal stalk. And type 2B, you find a slight funnel-shaped indentation towards the middle of the diaphragma sella is present. Type 3A, the diaphragma sella is composed of a 2 mm or a small peripheral veil, leaving the pituitary gland completely exposed and covered with arachnoid. Type 3B, the diaphragma sella is described for type 3A, but the pituitary gland is indented, often eccentrically. And type 3C, the deficient diaphragma sella is as described in type 3A. However, indentation of the pituitary gland is quite marked. An incomplete sellar diaphragm is an essential prerequisite. That is, an incomplete diaphragma sella is an essential prerequisite for the development of empty sella. All other factors only predispose to the development of the intracellular subarachnoid herniation, whether by causing increased pressure in the suprasellar subarachnoid space or by reduction in the size of the pituitary gland. Now let's see the primary empty sella syndrome and secondary empty sella syndrome. Primary occurs without a pituitary disorder. The mechanism is a congenital or acquired defect in the diaphragma sella, herniation of the subarachnoid space into the sella, associated with a raised IZP. Secondary empty sella syndrome occurs after damage to the pituitary gland. The causes are pituitary surgery. It can follow radiotherapy, a pituitary apoplexy following Sheehan syndrome, pituitary infarction, traumatic brain injury, and hypophysitis, pituitary adenoma regression. All these can in fact produce a secondary empty sella syndrome. By imaging, a classification is there: partial empty sella, complete empty sella. Partial empty sella is less than 50% of the sella is filled with CSF. The pituitary thickness is more than 3 mm. Complete empty sella. More than 50% of the sella is filled with CSF, and the pituitary thickness is less or more than 2 mm. Primary ESS. Incompetent or absent diaphragm sella, that is a pathogenesis. It can produce increased CSF pulsations, herniation of the arachnoid membrane into the sella, and progressive flattening of the pituitary gland occurs. The associated conditions that are associated with this, that is primary empty sella syndrome, are idiopathic intracranial hypertension or pseudotumor cerebri, obesity, hypertension, multiparity, and the female sex. Secondary empty sella syndrome is due to a destruction or shrinkage of the pituitary tissue due to the surgery, radiation, ischemia, hemorrhage, or autoimmune inflammation. It's more common in women, typically between 30 to 60 years, frequently associated with obesity, seen in up to 10 to 20% of MRI scans performed for unrelated reasons or incidental finding. Many patients are clinically asymptomatic. The neurological symptoms can be a headache. The most common symptom is chronic, non-specific it may be. Sometimes visual disturbances can occur, blurred vision, visual field defects, diplopia. Rarely an optic chiasmal prolapse can occur into the sella. Raised diazepy, transient visual obscurations, pulsatile tinnitus, papilledema, especially when associated with idiopathic intracranial hypertension. The endocrine manifestations common is the growth hormone deficiency, the most common abnormality, because of the pressure on the pituitary gland. Symptoms will be fatigue, reduced muscle mass, weight gain, gonadotropin deficiency. In women, amenorrhea, infertility can occur. In men, erectile dysfunction, decreased libido, hypothyroidism can occur, fatigue, weight gain, cold intolerance, adrenal insufficiency can occur, weakness and hypertension, hyperprolactinemia may occur due to pituitary stalk compression. Symptoms are galactorrhea and menstrual irregularities. Pan-hypopituitarism is very rare, but again it's important to consider. The ophthalmic features are a bitemporal hemianopia can occur, reduced visual acuity, papilledema, optic atrophy is quite rare. The gold standard for investigation is MRI. It is filled, CSF, the sella is filled with CSF, pituitary is flattened along the floor, and because the sella is filled with CSF and the pituitary is flattened along the floor. MRI also shows CSF signal within the sella, the flattened pituitary gland. The pituitary stalk can be seen traversing the sella. That is the infundibulum sign, which is a classical sign in empty sella syndrome, and with an enlarged sella turcica. The infundibulum sign is a highly useful feature. The pituitary stalk is seen centrally crossing the CSF-filled sella, and it helps distinguish the empty sella syndrome from cystic lesions. CT scan may show enlarged sella, CSF density filling, and flattened pituitary. The differential diagnosis: pituitary adenoma with cystic degeneration can be considered, Rathke cleft cyst, craniopharyngioma, arachnoid cyst, epidermoid cyst, postoperative sellar cavity, pituitary apoplexy. Now, all these have got differentiating features. Investigations, you do a hormonal assessment have to be done, ophthalmologic evaluation have to be done, and intracranial pressure assessment will have to be done. Hormonal assessment can be serum cortisol, ACTH, TSH, free T4, prolactin, FSH, LH, testosterone in men, estradiol in women. Ophthalmologic evaluation, visual acuity, visual fields, fundoscopy. Intracranial pressure assessment, if IH is suspected, lumbar puncture opening pressure can be measured, and MR venography to be done. The management in asymptomatic patients, no treatment is required, reassurance and periodic endocrine follow-up. Hormonal deficiency is there, then it has to be replaced, the deficient hormone. In adrenal insufficiency, hydrocortisone will have to be given. Hypothyroidism, levothyroxine. Hypogonadism, sex hormone replacement, and growth hormone deficiency, recombinant growth hormone in selected patients. If there is an associated idiopathic intracranial hypertension, then weight reduction, acetazolamide can be considered, topiramate, and CSF diversion procedures when indicated, especially monitoring the vision. Visual deterioration is rare, chiasmapexy, Neurosurgical elevation of the optic chiasm and visual loss is due to chiasmal herniation. CSF rhinorrhea may occur due to sellar floor erosion, and the management will be endoscopic transsphenoidal repair and lumbar drainage in selected cases. Prognosis generally excellent. Most patients remain stable. Endocrine abnormalities may require lifelong follow-up. Visual outcomes are usually favorable when treating early. The key points are empty sella is a CSF-filled sella with a flattened pituitary gland. Primary empty sella syndrome is commonly associated with obesity, female sex, multiparity, and idiopathic intracranial hypertension. And MRI is the investigation of choice. Infundibulum sign is characteristic. Headache is a common symptom. Growth hormone deficiency is the most frequent endocrine abnormality. Most asymptomatic patients require only observation. Hormone replacement is the main treatment when pituitary dysfunction exists. For a further reference, one can read the textbook of Neurosurgery, 4th edition, 2026, and that is by Prakash Naran Tanton as well as Ravi Ramamurthy. And it's a lovely chapter is there on empty sella syndrome by Ravi Ramamurthy, Murali Mohanes, and Chaitanya R.S. Page 2439 to 2446. It's worth reading, especially for postgraduates in neurology and neurosurgery. The other references, of course, Green's Handbook of Neurosurgery and the Williams Textbook of Endocrinology and the Pituitary Journal of Clinical Endocrinology and Metabolism. That's indeed briefly the features of empty sella syndrome. Thank you very much.